Welcome students. This is Dr. Deptee Warikoo, Department of Physiotherapy, Dolphin PG Institute of Biomedical and Natural Sciences. Our today's lecture is on biomechanics of wrist and hand. It will be comprising of two lectures, one biomechanics of wrist and another biomechanics of hand. So today we will be discussing about biomechanics of wrist joint. So, the hand consists of 5 digits, one thumb, and 4 fingers. There are 8 carpal bones present in the hand. The hand complex, there are 19 bones and 19 joints distal to the carpal bones. Now, the human hand has been characterized as a symbol of power, as an extension of intellect, and as the seat of the will. The wrist, which we are talking today, consists of two compound joints, the radiocarpal and the midcarpal joints, which are collectively referred as wrist complex. Each digit has a carpometacarpal joint and a metacarpophalangeal joints in the hand complex. Each finger has two interphalangeal joints, one DIP and one proximal, except the thumb having only one interphalangeal joint. So, beginning with the wrist complex. The wrist complex, which comprises mainly the two joints, as I told you earlier, the radiocarpal and the midcarpal joint. Here you could see in the figure the radiocarpal joints and the midcarpal. The joints present between the carpal bones is the midcarpal joint. So the major contribution of wrist complex is to control length tension relationship in multi-articular hand muscles and to allow those fine and adjusting movements or the grips of the hand. Wrist muscles are designed for balance and control rather than maximizing torque production. Wrist complex as a whole is considered to be biaxial, with motions of extension flexion around a coronal axis, ulnar deviation, radial deviation around anterior posterior axis. The ranges of motion of the entire complex are variable and reflect the difference in the carpal kinematics. This arise from such factors like the ligament laxity, the shape of the articular surfaces, and the other constraining effects, though, which are mainly produced by the muscles. So, if we discuss about the normal varying ranges of the wrist joint, we see flexion could be around 60 to 85 degrees, extension could be around 60 to 85 degrees, the radial deviation could be around 15 to 21 degrees, ulnar deviation could be around 20 to 45 degrees. The two joint rather than a single joint complex which we see in the wrist complex mainly provides one a large range of motion with less exposed articular surfaces. Also, there are tighter joint capsules. Then, second, less tendency for structural pinch at extreme ranges. And third, flattened multi joint surfaces that are more capable of withstanding imposed pressures. Now, let us first start with radiocarpal joint structure. The radiocarpal joint is formed by radius and radioulnar disc as a part of the triangular fibrocartilaginous complex, which we all call as TFCC proximally, and by the scaphoid, lunate, and triquetrum distally, which you could see in this diagram. The yellow part, the radius, the blue one is the articular disc, then the green parts are scaphoid, lunate, and triquetrum. Now, discussing about the proximal and distal segments of the radiocarpal joint. The distal radius has a single continuous biconcave curvature that is long and shallow side to side and shorter and sharper anterior posteriorly. The proximal joint surface is composed of 1. The lateral radial facet, which articulates with scaphoid. 2. The medial radial facet, which articulates with the lunate. And 3. The TFCC, the triangular fibrocartilaginous complex, which articulates predominantly with triquetrum, although it also has some contact with lunate in the neutral when the wrist is in neutral position. Then the radio-ulnar disc is a component of the TFCC. It also serves as a part of distal radio-ulnar joint, as I told you earlier. Proximal radiocarpal joint surface is oblique and angled slightly volarly and ulnarly. The average inclination of radius is 23 degrees and tilted 11 degrees volarly, with the posterior radius slightly longer than the volar radius. Here you could see the inclinations of the radius. The average inclination of distal radius is, as you see in the first diagram, it is 23 degrees. Now discussing about the triangular fibrocartilaginous complex. It consists of the radioulnar disc and the various fibrous attachments that provide the primary support for the distal radioulnar joint. Although the attachment contributes to the TFCC vary somewhat, like we could see the variations, the articular disc is a fibrocartilaginous continuation of the articular cartilage of the distal radius. The disc is connected medially via two dense fibrous connective tissues that are the laminae. The upper tissue, that the upper laminae, that include the dorsal and volar radial ulnar ligament, which attaches to the ulnar head and ulnar styloid. The lower lamina has connections to the sheath of the extensor carpi ulnaris tendon and to the triquetrum bone, hamate, and the base of the fifth metacarpal through fibers from ulnar collateral ligament. Okay, so this is so called meniscus homologue, is a region of irregular connective tissue that lies within and is part of the lower lamina, with transverse volar and ulnar from the dorsal radius to insert onto the bone, that is your triquetrum bone. Now along its path, the meniscus homologue has fibers that insert into the ulnar styloid and contribute to the formation of what we called as pre-styloid recess. Okay. Overall, TFCC functions at wrist as an extension of the distal radius. So this is very important. Here you could see the diagram of all the structures along the dorsal TFC. Scaphoid, lunate, and triquetrum form the proximal carpal row. This proximal carpal row articulates with the distal radius. These bones are interconnected by two ligaments that, like the carpal themselves, are covered with cartilage proximally. These ligaments are scapholunate interosseous and the lunotriquetral interosseous ligaments. Proximal carpal row and ligaments together appear as a single biconvex cartilage covered joint surface that can change shape to accommodate the demands of the space between forearm and hand. It depends on in which position your hand is currently. The pisiform, anatomically part of the proximal row, does not participate in the radiocarpal articulation. It is very important fact which you need to know. The pisiform functions entirely as a sesamoid bone, presumably to increase the moment arm of the muscle in which it is inserted, that is flexor carpi ulnaris. In radiocarpal joint, distal surface is sharper than proximal both in coronal as well as sagittal plane. This makes the joint an incongruent joint. This causes greater range of flexion and extension and greater ulnar deviation than radial deviation. The joint incongruency and the angulation of the proximal joint surface results in greater range of flexion than extension and in greater ulnar deviation than radial deviation for the particularly the radiocarpal joint. As the curvature and inclination of the radiocarpal surfaces affects the function, the length of the ulna in relation to the radius also has got lot of effect on your joint. Okay, not only do the curvature but this length also affects. So we have here two types of things which we have to consider. First is the ulnar negative variance, another is the ulnar positive variance. Ulnar negative variance is described as short ulna in comparison with the radius at their distal ends, whereas in ulnar positive variance the distal ulna is longer in relation to the distal radius. When an axial load is applied to the wrist, the scaphoid and lunate receive approximately 80% of the load, whereas the triangular fibrocartilaginous complex receives approximately 20%. At the distal radius, 60% of the contact is made with the scaphoid and 40% with the lunate. So, what will happen when this positive or negative ulnar variance is present? With an ulnar positive variance, there is a potential for impingement of triangular fibrocartilaginous structures. So, we could say that when there is positive ulnar variance, that we could see some impingements over there. Ulnar negative variance may result in abnormal force distribution across the radiocarpal joint. That will potentially cause degeneration at the radiocarpal joint. So we could say negative ulnar variance may lead to some degeneration, which may lead to abnormal force distribution at the radiocarpal joints, and there could be avascular necrosis of the lunate, that is Kienbock's disease. So when there is a Kienbock's disease, there is a possibility of having a negative ulnar variance. Now we will talk about radiocarpal capsule and the ligaments. The radiocarpal joint is enclosed by a strong but somewhat loose capsule and is reinforced by capsular and intercapsular ligaments. Most ligaments that cross the radiocarpal joint also contribute to stability at the midcarpal joint. And so all the ligaments will be presented together after introduction of the midcarpal joint. Okay. So stability will depend mainly on these ligaments. Now we will talk about the midcarpal joint structures and the structures present there. The midcarpal joint is the articulation between the scaphoid, the lunate and triquetrum proximally, and the distal carpal row comprises of trapezium, trapezoid, capitate and hamate. The midcarpal joint is a functional rather than anatomical unit because it does not form a single uninterrupted articular surface. However, it is anatomically separate from the radiocarpal joint and has its own capsule and synovial lining that it continuously with each intercarpal articulation and may be continuous with some of the carpometacarpal articulations also. The midcarpal joint surfaces are complex with an overall reciprocally concave convex configuration. The complexity of surfaces and ligaments that are connected there, however, simplify its movements. Together, the bones of the distal carpal row contribute 2 degrees of freedom to the wrist complex with varying amounts of radial ulnar deviation and flexion extension created to the joint. Okay. So the functional distal carpal row moves as a fixed unit. So union of distal carpals also result in equal distribution of loads across scaphoid, trapezium, trapezoid or scaphoid capitate or capitate lunate or other carpal structures. So, the functional union of distal carpals with each other and with their continuous metacarpals not only serves the wrist complex but also are the foundation for the transverse and longitudinal arches of the hand. Students, you have to remember it. It will be also discussed in later classes, which will be comprising the hand joints. Now, what are the ligaments of the wrist complex? The ligamentous structures of carpus is responsible for articular stability as well as guiding and checking motions between and among the carpals. So, the tremendous individual differences that exist in the structure of carpus can perhaps be appreciated when we read about the ligaments and how they control it properly. So the ligaments could be extrinsic ligaments and intrinsic ligaments. The extrinsic ligaments connect carpals to radius, ulna proximally or metacarpals distally. And the intrinsic ligaments interconnect the carpals. So ligaments will be divided into two sections. One will be volar carpal ligaments and another will be dorsal carpal ligaments. So before going into volar and dorsal components, see there are intrinsic and intrinsic ligaments, how we describe them. The extrinsic ligaments are carpals to radius and intrinsic are between the carpals. The extrinsic ligament are contiguous vascularized tissues, but the intrinsic are through the synovial fluid. There is high risk of injury to the extrinsic ligaments and low risk of injury to the intrinsic ligaments. The extrinsic ligaments heal fast, but the intrinsic ligaments take time to heal. Now, first we will discuss about the volar carpal ligaments. These volar carpal ligaments are present on the volar surface of the wrist complex, and they comprise of two groups. One is the radiocarpal and ulnocarpal ligaments. These together are known as volar radiocarpal or volar ulnocarpal ligaments. The volar radiocarpal ligaments is described most commonly as having three distinct bands: the radioscaphocapitate ligament, the radiolunate ligament, and the radioscapholunate ligament. The radioscapholunate ligament was once described as the most important stabilizer of the proximal scaphoid. Then we have the radial collateral ligaments, which may be considered as extension of the volar radiocarpal ligament and capsule. And then we have the ulnocarpal ligament complex. It is composed of the triangular fibrocartilaginous complex, including articular disc and meniscus homologue, ulnolunate ligament and ulnar collateral ligament. Two volar intrinsic ligaments have received particular attention. These two ligaments, the ulnar and the radial ligaments. So next are the scapholunate introitious ligaments. They maintain the scaphoid stability and wrist stability. Then the lunotricuteral introitious ligaments, which maintain the stability between the lunate and tricuterum. In general, the volar wrist ligaments are placed on stretch with wrist extension. Then we come to dorsal carpal ligaments. Dorsally, the major wrist ligament is the dorsal radiocarpal ligament. This ligament, as is true for the volar radiocarpal ligament, varies somewhat in description but is obliquely oriented. Then there is dorsal intercarpal ligament, which courses horizontally from the tricuterum to the lunate, scaphoid and trapezium. Together these form a horizontal V that contributes to radiocarpal stability. And these ligaments are taut with wrist flexion. So before going further, let us sum up the ligaments. The extrinsic ligaments are radiocarpal, radiocollateral, volar collateral, then radioscaphocapitate, radiolunate, radioscapholunate. Then we have the ulnocarpal, that is the TFCC, meniscus homologue, ul- ulnolunate, ulna collateral. Then we move to dorsal carpal ligaments. These are again intrinsic ligaments are the short ligaments, then intermediate ligaments and the long ligaments. These are the ligaments of the wrist complex. You could see all the ligaments. Here what you can see, the tricutrocapitate ligament, this is the V-shaped ligament, and the scaphocapitate ligament. Here you could see this V deltoid. This is called the deltoid ligament of the hand. Now starting off the functions of the wrist complex. So first we will be discussing about the movements of radiocarpal and midcarpal joints. Motions in the radiocarpal and midcarpal joints are caused by a rather unique combination of active muscular and passive ligamentous and joint relation forces. Although there are abundant passive forces on the proximal carpal row, as we have discussed earlier, no muscular forces are applied directly to the articular bones of the proximal row. The proximal carpals, therefore, are effectively a mechanical link between the radius and the distal carpals and the metacarpals, to which the muscular forces are actually applied. So first we will discuss about the flexion extension of the wrist. During flexion extension of the wrist, the scaphoid seems to show the greatest motion of the three proximal carpal bone, whereas the lunate moves the least. The movement of the complex from complete flexion to extension could be seen in three basic phases. In the first phase, the motion begins with the wrist in full flexion. The active extension is initiated at the distal carpal row and at the firmly attached metacarpals by wrist extensor muscles attached to those bones. The distal carpals, which are the capitate, hamate, trapezium, and trapezoid, they glide on the relatively fixed proximal bones. Although the surface configuration of the midcarpal joints are complex, but the distal carpal row effectively glides in the same direction as motion of the hand. When the wrist complex reaches the neutral, the ligaments spanning the capitate and scaphoid draw the capitate and scaphoid together into a closed pack position. Then second stage starts. Continued extension forces now moves the combined unit of the distal carpal rows and the scaphoid on the relatively fixed lunate and triquetrum. At approximately 45 degrees of extension, the wrist complex, the scapholunate interosseous ligament, brings the scaphoid and lunate into closed pack position. This unites all the carpals and causes them now to function as a single unit. Then starts the third phase, that is the completion of the wrist extension. It occurs as a proximal articular surface of the carpal moves as a relatively one solid unit on the radius and the triangular fibrocartilaginous complex. And when we talk about extension to flexion, it is absolutely the reverse process, what I just told you. The next movement is the radial and ulnar deviation. Radial and ulnar deviation of the wrist seems to be an even more complex but a perhaps less varied motion than the flexion extension. The carpal slide ulnarly over radius with simultaneously flexion of the proximal carpals and extension of the distal carpals. And this occurs in radial deviation. Exactly opposite occurs in ulnar deviation. In full radial deviation, both the radiocarpal and midcarpal joints are in closed pack position, and the ranges may vary according to the wrist position. That means whether your wrist is in neutral, flexed, or fully extended. Depends on the position of your wrist. So next is muscles of the wrist complex. Before going into muscles of the wrist complex, let us discuss about the wrist stability, because now we know the stability of the wrist is comprising on three basic structures. First is the ligaments, second the osseous structure, and third are the muscles. So any injury to the ligaments will cause instability in the wrist. Injury to one or more of the ligaments attached to the scaphoid and lunate may diminish or remove the synergistic stabilization of the lunate and scaphoid. The muscular forces that bypass the proximal carpals and apply force to the distal carpals cause the distal carpals to flex on the extended lunate and triquetrum, because there is a zigzag pattern of three segments, that is the scaphoid, the lunate, the triquetrum, and the distal carpal row. So this is known as intercalated segmental instability. When the lunate assumes an extended posture, this is called as dorsal intercalated segmental instability, or DISI. A DISI problem therefore may result over time in degeneration, and there could be changes in the radioscaphoid joint. The progressive degeneration uh, due to this DISI is known as scapholunate advanced collapse or a slack wrist, which you will read in your later classes. They could be carpal instability also, uh, that is volar intercalated segmental instability, or VISI. So instability of the wrist joint will will have a great impact on the movement of the wrist joint. So now, what are the muscles of the wrist complex? The primary role of the muscles of the wrist complex is to provide a stable base for the hand while permitting positional adjustments that allow for an optional length tension relationship in long finger flexors. So the muscles will be divided into two basic components of volar muscles and the dorsal. Volar muscles of the wrist mainly cause flexion, and dorsal muscles mainly cause extension. First, we'll be discussing about the volar wrist musculature. There are six muscles and have tendons cross the volar aspect of the wrist and therefore are capable of creating a wrist flexion movement. These are mainly the palmaris longus, the flexor carpi radialis, the flexor carpi ulnaris, the flexor digitorum superficialis, the flexor digitorum profundus, and the flexor pollicis longus muscles. The first three of these muscles are primary wrist muscles. The last three are flexors of the digits with secondary action at the wrist and the wrist level. All of the volar wrist muscles pass beneath the flexor retinaculum along with the median nerve except the palmaris longus and flexor carpi ulnaris muscle. This retinaculum prevents bowstring of these long tendons. That is the main function of the retinaculum. The flexor retinaculum is often considered to have a proximal portion and a distal portion. With the distal portion, more commonly we call it as transverse carpal ligament, which forms the roof of your carpal tunnel. Next are the distal wrist musculatures. The dorsum of the wrist complex is crossed by the tendons of nine muscles. Three of the nine muscles are the primary wrist muscles, that is extensor carpi radialis longus and extensor carpi radialis brevis and extensor carpi ulnaris. The other six are the fine finger and thumb muscles that may act secondary on the wrist. These are the extensor digitorum communis, the extensor indicis proprius, and the extensor digiti minimi, the extensor pollicis longus, the extensor pollicis brevis, and the abductor pollicis longus. The extensor digitorum communis and the extensor indicis muscles are also known more simply as the extensor digitorum and the extensor indicis proprius. The tendons of all 9 muscles pass beneath the extensor retinaculum, which is divided into 6 tunnels, as you have already read in your anatomy sections. And these tendons pass beneath their separate tunnels through which they pass below the extensor retinaculum and move towards the hand. The functions of all these muscles you have read in your classes. The you need to know about their origin, insertion, nerve supply, and action. So this was about the basic biomechanics of the wrist complex. I hope you all understood about the basic things. If there are any queries, you could contact me on my email ID or WhatsApp me or also call me. So next class we will be starting off with biomechanics of the hand complex. Thank you till then.